Hello, everyone. Welcome to this PCR webinar, Imaging the Journey of a Patient with Severe Tricuspid Regurgitation from Diagnosis to Management. This PCR webinar is supported by GE Healthcare and is brought to you by a distinguished panel, among them Professor Denisa Muraru from the Istituto Ausiologico Italiano in Milan, Professor Erwan Donal from Rennes in France, and Professor Asim Latif from Montefiore Medical Center Moses Division in New York. All of them will teach us what to do in patients with tricuspid regurgitation and will teach us tips and tricks on screening and patient selection for transcatheter tricuspid valve interventions. We will also learn new echo imaging solutions to help better understand tricuspid valve anatomy in 3 dimensions, and also the imaging challenges that we may face to guide the transcatheter tricuspid valve interventions and how to overcome them with new technologies, such as, for example, echo CT fusion, 2D, and 4D eyes. I welcome you to send your questions through the chat. My name is Victoria Delgado from the Leiden University Medical Center, and I will be happy to handle your questions and discuss with the panel. Without further ado, I would like to introduce Denisa Muraru, who will enlighten us on the selection of the most appropriate transcatheter tricuspid valve intervention. What do I need to know? Denisa, please.
Thank you, Victoria. Good evening, everyone. Indeed, the journey of the patient with tricuspid regurgitation starts with the diagnosis, and this happens most of the time in the echo lab. Therefore, in the following presentation, I would like to discuss with you how we should approach the patient and which are the key information that we need to provide with imaging. First of all, we need to have a stepwise approach that starts with the severity of the TR, the classification, then looking to the detailed anatomy of the tricuspid valve apparatus, and finally, the definition of the jet origin. Of course, when we are facing a patient with a suspected or known severe TR, first of all, we have to visually estimate the size of the regurgitant jet, but also look to first clues that the TR is severe, like coaptation gap, or if there are flay leaflet or significant right atrial or annulus dilation. For this, conventional views are useful, but for instance, when we are having very small, very limited coaptation gaps, the new visualization tools could be also very useful. Finally, an important caveat is that if the previous examination was done with the patient decompensated, it is really important to reevaluate again all the parameters of severity in order to make sure that the TR is actually severe. How to do that? It is not enough to visualize the TR. We have to measure and provide not only all the parameters that have been recommended by the guidelines, but also have a more detailed analysis like 3D vena contracta area, which accounts for the asymmetry of the regurgitant orifice. And we know that single dimensions of the vena contracta may be misleading, and we should make an effort to provide biplane average of the vena contracta and also indirect signs of Doppler for assessing the severity of TR. How we should define severe TR, this is still a matter of debate currently. We have realized that 3 grades are not enough when considering the patient with for an intervention, and either you apply 4 or 5 grades, but we should define how severe is the severe TR. And most importantly, rather than grading, it is important to provide the measurements, because the absolute numbers are much more important than cutoff to define the severity. We know that the risk increases continuously, and the outcome worsens even with moderate TR, and this is really established. So the outcome is not necessarily synonymous with severe TR, and we should provide measurements. And then we need to classify the TR. And conventionally, we used to apply this dichotomic separation in primary and secondary, or functional and organic. Functional is the most prevalent in patients that do not have any clear cause of TR, and the patient has atrial fibrillation. The guidelines labeled this as an isolated tricuspid regurgitation. However, this dichotomic separation is quite insufficient to account for the heterogeneity of the patients that we see in our practice with functional tricuspid regurgitation. They have quite different remodeling of the right ventricle, as you can see from this three-dimensional study, as well as different patterns of annular dilation, tethering of the leaflets, and of the right atrium. And what we identified practically are two phenotypes of functional TR. One, the first one in pulmonary hypertension, left heart disease, that's more linked to a dilation of the right ventricle. And the second, that it is more linked to a dilation of the right atrium, which has very large annuli, but minimal or no tenting of the leaflets. This is really important. So nowadays, we should make a further separation of patients with functional TR in ventricular form and in the atrial form, which is not infrequent. It's 1/4 of our patients. And as you can see in the first category, the conventional ventricular cause, the predominant mechanism is not the annular dilation, but is the leaflet tethering, while in the second, in atrial FTR, is the annular dilation. And you see there, if you look at the assumptions that we are considering for the PISA method, you see that we are assumed that the leaflets are flat, which is not actually verified in most of our patients with ventricular functional TR because they have tethered leaflets. Therefore, it emerged the concept to correct for this tethering and to account in the PISA formula for the tethering of the leaflets. And we have provided this data and presented at EuroEcho. We have seen that if you apply angle correction to TR patients, this has led to a significant change in TR severity in 1/3 of the cases. And it seems to have a greater concordance with the 3D volumetric method of TR severity. Therefore, it seems to have an added benefit, particularly in the ventricular form of functional TR, and probably it is less useful in atrial forms. This study was published just a few days ago. This comes from the Cleveland Clinic. They had a retrospective analysis of an impressive number of consecutive patients. They looked at predictors for 1 year all-cause death and emphasized once again that it is important to stratify in atrial functional TR, which has a better outcome, with respect to the ventricular forms. The worst outcome is the TR due to pulmonary hypertension, as we expected. And they also provided a risk score to predict the mortality at 1 year. And you can see from an imaging standpoint, it's the right ventricular function and pulmonary pressure, and no parameter of TR severity. Therefore, due to these considerations, we should no longer apply idiopathic or isolated TR, but we should refer to this new proposed classification that comes from the PCR tricuspid focus group. Why? Because in principle, of course, there are exceptions, but in principle, patients that have atrial functional TR are the ideal candidates for annuloplasty. Patients that have a less annular dilation but more tethering, the ventricular functional TR, could be considered for leaflet approximation. But if the valve is very damaged, there is a severe tethering, severe annular dilation, or there is a primary cause or leaflet impingement, we should probably replace the valve. And this is how it is taken, the decision, more or less. Obviously, then there are some important details that Erwan will present to you. And so going on with a stepwise approach for imaging the patient with TR, we reach to the anatomy, which is tremendously important when it comes to intervention repair of the tricuspid regurgitation. And this is the opposite from the surgical repair. We have to have very detailed analysis of the leaflets and of the annulus. And from the leaflets, it is not only important the number, but also the length, the depth, the tethering, and so on. This should be provided with a very detailed protocol, including views that are not in the conventional study. So we have to become expert in acquiring transgastric and deep esophageal views. We will see that in the next presentation. But most importantly, we should be expert in using three-dimensional echocardiography, because we are dealing with a very complex anatomy and very complex chambers, which are very difficult to evaluate with conventional tomographic images. This was nicely shown recently by Becky Hahn and co-workers, who, after applying 3D and transgastric views consecutively in patients with TR, she saw that actually 46% of the patients do not have a 3-leaflet valve, and actually there are many patients that have 4 leaflets. This has significant implication, of course. Here you have some examples acquired by 3D transthoracic imaging. The point here is that whenever you have difficulties to get these images from transesophageal, remember that the patient has also a transthoracic window, and sometimes you might be able to provide this information also with transthoracic if you have some issues with artifacts in transesophageal. 2D views are completely unremarkable, so there is no way to identify the anatomy based on 2D imaging. Finally, it is important to look at the relationship between the leads and the leaflets, because if you have an impinging lead on a leaflet, this is not feasible for annuloplasty or for edge-to-edge repair, and most of the time it requires replacement. Annulus sizing, the standard procedure for annulus sizing is the CT, because it allows to assess not only the size of the annulus, but also to see the relationship with the right coronary artery. However, there is an important caveat, because many of our patients have atrial fibrillation. And recently, this very elegant study from the Mayo Clinic showed that there is quite a significant variability beat to beat in the measurement of the annulus, and also the maximal size is reached in different moments of the cardiac cycle, meaning that if you measure in a predefined time point, for instance, end diastole, you will likely underestimate the annulus size if the patient has atrial fibrillation. And this underscores the importance of continuous annulus tracking as a prerequisite for accurate sizing of the annulus. This is now possible with three-dimensional echocardiography that allows not only to assess the complexity. For instance, here you see type 3B with 2 posterior leaflets and the complexity of the regurgitant orifice, but we have also the issue of the variability of the regurgitant orifice size and shape from beat to beat in atrial fibrillation, which adds more challenge in these anatomically complex valves. This is an example of a patient that underwent screening with 2D and 3D echocardiography. We found that the annulus was really dilated, and there was also very severe tethering of the leaflets. And this information has been confirmed by CT. And in the end, this patient, the decision was to replace the valve, and it was navigated by a prosthesis implanted with a good result. Finally, according to the guidelines, it is important to assess and to exclude the presence of a severe right ventricular dysfunction and a severe pulmonary hypertension for eligibility for the procedure. But the guidelines do not mention how to measure actually the RV, or what is a severe RV dysfunction. And one of the very few indications in the ASC guidelines is here to use strain and 3D measurements of the RV volumes that allow to overcome the limitations of conventional right ventricular function indices. This is a very nice study from Victoria's lab, showing that strain is more sensitive to detect RV dysfunction with respect to conventional parameters and is able to predict outcome. And finally, there is the concept to improve the evaluation of RV function with three-dimensional echocardiography by correcting the ejection fraction of the RV for the pulmonary pressure. And to obtain a non-invasive RVPA coupling assessment that in this recent study that we have presented at EuroEcho seems to predict outcome of the patient. So in conclusion, imaging is central for the selection of best interventional approach. Heart valve center with in-depth knowledge of 3D functional anatomy, specific expertise in modality 2D and 3D imaging is important, and accurate measurements that are obtained with dedicated tools for the right heart are pivotal for understanding the TR pathophysiology and to assess the immediate and long-term effects of devices on tricuspid valve anatomy and function. Thank you very much for your kind attention.
Thank you very much, Denisa. Excellent presentation and excellent images. I'm always very jealous because the tricuspid valve is very difficult to image with 3D. We have already questions from the audience, and one of the questions is regarding the quantification of tricuspid valve regurgitation. And Dr. Ekaterina Stelbrings asked us if the biplane vena contracta does it correspond better to the real defect size than the EROA? What's your opinion here? How do you assess it? Do you go for 2D vena contracta with biplane or 3D vena contracta, and which cutoff value?
So ideally, we should use the 3D vena contracta whenever feasible. But of course, 3D has also some limitations in terms of temporal resolution. Sometimes the definition of the 3D color is not very clear, and we have to rely on longitudinal 2D views because have a higher spatial resolution. So the average vena contracta is a surrogate and not necessarily reflecting a better measurement, but it is much better than a single plane measurement and takes into account the elliptical orifices that we are sometimes having in patients with functional TR, which usually display the shortest distance, so the shorter vena contracta in the four-chamber view. So this is one way but we know from the mitral regurgitation that just the biplane will not be necessarily the gold standard, and we should try to have a short axis visualization of the regurgitant orifice and try to planimeter, especially when we are having patients that have been already treated, and we have to evaluate also the post-interventional results. There you might have different orifices, different jets, and becomes even more important to have a 3D assessment.
That's a very important issue what you raised, because actually to compare pre and post the intervention, after the intervention on transcatheter intervention, we have sometimes difficulties on how to grade that. We can have a reduction, but which vena contracta do we use, which orifice or which defect. So for you, for example, the classification on 5 grades, where we have severe, massive, and torrential, you have elegantly showed that actually there is an excess of mortality at each degree. The larger the defect is, the larger the regurgitation is, the worse the prognosis. But in your opinion, for example, we are all working in centers that are half-valve centers where they have all the possibilities, transcatheter, surgical. We have heart teams dedicated for valvular heart disease. But in many centers, the teams may not be able or may not be performing those interventions, and they need to refer to the center. So what would be your advice, for example, for those centers that have the patient with tricuspid regurgitation and may need to refer to the heart valve center? Would you wait for massive and torrential, or would you recommend referring the patient earlier to the heart valve center where the entire analysis can be performed?
No, that's a very good question. Of course, early it's much better, and this has been very clearly emphasized by the recent guidelines on valvular heart disease. Early referral is fundamental. We should not wait until the RV is severely damaged, until the gap is too large to be fixed. And we need to refer them as soon as possible if the patient is symptomatic, in order to evaluate for the feasibility of transcatheter. The 5 grade is important for the outcome, and it's important to assess the post-interventional result, because even if the TR is still in the range of severe, it seems to provide still benefit for the patient in terms of hepatic congestion and functional capacity.
That's very important indeed. And continuing with the quantification, actually, that seems that is the main topic. Dr. Danilenko asked us, when you measure the 3D vena contracta area, do you change the baseline shift and the location of the measurement under the leaflets or at the level of the leaflet plane? What is your practice?
Usually, I downshift a little bit the baseline if I have trouble visualization, clear contour of the vena contracta, and then I place the plane at the level of the smallest region of the jet, so just below the convergence zone.
Perfect. And regarding the type of tricuspid regurgitation, Dr. Stelbrink also asked us which atrial tricuspid regurgitation you consider that is best for edge-to-edge therapy and which one you consider that is best for annuloplasty initially. Do you have any preference? How do you decide that? If you can give us some advice.
In atrial functional TR?
Yes.
So in atrial functional TR, this if there is no tenting and RV is good, usually these are the most appropriate candidates for annuloplasty if there is expertise for annuloplasty in that center, because also this influences a lot on the choice of the devices to be placed. If there is an atrial functional TR that has evolved for a long time, that has led to a significant RV dilation and dysfunction, and the leaflets are already tethered, then it is much more difficult to solve it with annuloplasty and might even aggravate the tethering of the leaflets. So either the valve should be replaced in that case, or it can be a combined intervention, edge-to-edge and annuloplasty.
Yeah, that's very important. Thank you so much, Denise. I think that we can move forward with the journey, and it's my pleasure to introduce Professor Donald from France, who will tell us on the periprocedural imaging in transcatheter tricuspid valve intervention. Erwan.
Thank you very much. Thank you for the invitation. Thank you, Victoria. It's a nice pleasure for me to be with you today and to discuss about this hot topic of the tricuspid regurg and its treatment. So, of course, when we have a patient with a significant TR and with symptom, we think that, first of all, we have to implement the treatment and to optimize the treatment, the medical treatment, the diuretics, and then sometimes the patient remains symptomatic, and then we have to decide if we send the patient to surgery, which is very unusual, or if we can treat the patient with a percutaneous approach. And then we have different treatments. We have the clips, we have the cardioband, and we have prostheses that are now available. And then we will have to use the imaging techniques to see what are the pitfalls for each techniques and what are the advantages for each techniques. And then we have to keep in mind, and Denisa told us already a lot about that the tricuspid valve is very, very complex. And actually the anatomy of the tricuspid valve is changing from one patient to another. And we have to keep in mind that some patients have a tricuspid regurg related to the dilatation of the right ventricle, and some patients have a tricuspid regurg that is related to the change in shape of the right atrium. And of course, it has been said already, there is a last kind of tricuspid regurg that is related to the fact that there is a lead, a pacemaker lead, across the tricuspid valve. And then we have to use the TTE and the TEE, the 2D, the 3D, to optimize our understanding of the tricuspid valve anatomy. And then we will be probably able to best select the treatment that we will choose for the patient. In regard to the TEE, it's quite important. It has been said, but I want to emphasize that we have to use very specific views. And actually, we use the transesophageal view with the biplane mode and the 3D mode. And also, we really have to use the deep transesophageal view, because this deep transesophageal view is crucial to best see the leaflets and the gap between these leaflets. And more important also is the ability that you have to perfectly see the 3 leaflets using the transgastric view. You really have to make sure that you see perfectly the 3 leaflets if you want to use edge-to-edge repair, for instance. If you don't see the septal leaflet, you will not be able to grasp this leaflet. Therefore, you really have to be an expert in transgastric view if you want to guide the treatment of a tricuspid regurg using clips, for instance. And then you have to know about the anatomy of the leaflets, and you know that the anterior leaflet is the longest one most of the time. The septal leaflet is the more ventricular-oriented one, and the posterior leaflet is the more complex, triangular, and most of the time there are multiple scallops that are making this posterior leaflet. And I really want to emphasize what has been said by Denisa. We have the primary TR that are quite rare. We have the functional TR related to the RV, related to the RA, and related to the pacemaker leads. And then if we have to select the device that we will use, we really have to understand why is there a TR? Do we understand where the jet is coming from? And also we have to make sure that when we will be in the operating room, we have to be convinced that we will be able to guide the implantation of the devices. For instance, you have this example of a patient with calcification of the pericardium, and this calcification of the pericardium prevents us to see perfectly the septal leaflet. And then it was very difficult to implant clips for this patient. So we have to make sure that we see the Eustachi valve, we have to see the pacemaker leads, we have to see the lipomatous hypertrophy of the interventricular septum, we have to see for the calcification, and we have to make sure that there is no prosthesis on the left side. If you have a mechanical prosthesis on the mitral valve, for instance, it will be more challenging to implant clips in this patient on the tricuspid valve. Okay, and then we have this paper that has been shown already by Denisa, made by our group at the PCR level. And you see that there are some anatomic considerations that can be taken into account to decide if we will implant clips or not. And if the gap between the septal and the lateral leaflet or the anterior leaflet is lower than 7 millimeters, it's probably a good candidate for clips implantations. If the gap is greater than 8.5 millimeters, then probably the patient is not a perfect candidate for clips, and then we will have to move to something else like annuloplasty or prosthesis. But as you see on the images, you have to get nice images, but still, if you have nice images, it is still complicated to measure perfectly the gaps and the gaps in the location where you are supposed to implant the clips. And then you have to keep in mind what has been said by Denisa. Most of the time we have 3 leaflets, but at least in 1/3 of the patients that you will see with a severe TR, you will have a grade 3B of tricuspid, not a grade, but a type 3B, which means that you will have 2 posterior leaflets. And if you have 4 leaflets, you know that it will be much more complicated to deal with the tricuspid regurg when you implant clips. If I can have the next slide, please. Okay, so just an example of a patient, a 72 years old man with a severe right heart failure. And as you can see, we use all the capabilities of our echo machine to implant 3 clips to deal with the severe TR of this patient. So we use first the transesophageal approach. And as you can see on the left side, we have an important Eustache valves, and the Eustache valves could be an issue if we want to move perfectly the device in the right atrium. And then we will use the transesophageal approach, the biplane mode, to guide the motion of the catheter in the right atrium. And then we will move to the transgastric view to perfectly cross the valve and to put the device in the perfect location where we want to implant the device. And most of the time, we start by implanting devices between the septal and the anterior leaflet. In the present case, we used the CT fusion also to make sure that we understand perfectly the size of the annulus, and I will discuss that furthermore. And in the present case, we were able to implant 3 clips, and thanks to 3 clips, there were quite no tricuspid regurg after the implantation, and the gradient across the valve was very low. It doesn't work. Okay. This is another example of the use of the echo machine and the combination of the CT and the echo machine to be able to measure perfectly the size of the tricuspid annulus and the shape of the tricuspid annulus. Because if there is a too important flattering of the tricuspid annulus with a too important dilatation of the tricuspid annulus, it will be much more complicated to deal with clips, and sometimes also it's not suitable for implantation of percutaneous tricuspid prosthesis. And then we will have to deal with annuloplasty only. And you see that we can use both the CT and the echo to measure this annulus using the 3D capabilities of your echo machine. You can combine the CT and the 3D echo to best assess the anatomy of the tricuspid annulus, but also of the right ventricle and the tricuspid valve. Here you have an example of a patient where we were able to implant a transcatheter tricuspid prosthesis, and it was much easier to implant this device thanks to the combination of the 3D echo and the CT during the intervention. You see, for instance, in that example, that the combination of the CT and the echo made us much easier to see where is the moderator strip, and the fact that we were able to see the moderator strips was of key importance to implant properly the prosthesis across the tricuspid valve and within the RV. And then we can also use these 3D capabilities and the CT, both images fusion in the echo machine, to implant a cardioband, for instance. And this is an example that I got from Victoria. And you see, this is a patient that has been treated first by clips, but there was not a perfect result after the implantation of the clips. And then Victoria's team decided to implant a cardioband. And as you see on this example, it's much easier to see the hinge point using the biplane mode. And sometimes it's even better if you can use the flexi-slice mode, because thanks to the flexi-slice mode, you have the 3D acquisition of the right ventricle and the right atrium, and you can move across this volume to perfectly see where is the catheter and where is the hinge point. And then sometimes, even with the flexi-slice modality, you cannot see perfectly the hinge point. And then in this example, you see that it was very useful to use also a nice catheter to perfectly see the catheter and the hinge point. And thanks to all this images capability, it was possible to implant the cardioband. And you see that we can again use the fusion between the echo, the 3D echo, and the CT to perfectly see using the CT that has been recorded before the implantation or after the implantation, and using the echo that is acquired during the implantation or after the implantation, you can perfectly see how you can combine these two images to best see the implantation of the device. And then you see the result at the end. You have 3 clips and the cardioband, and quite no more tricuspid regurg after the device's implantation. And it was much easier to be done thanks to this 3D, thanks to the CT, and also thanks to the use of the ICE catheter. So really, I want to emphasize that TR is an issue nowadays. We see a lot of patients that are symptomatic with a very severe TR. We have to really understand the mechanisms that leads to this TR, and we have to understand the size, the shape of the right atrium, and the size, the shape, and the function of the right ventricle. And then we will use the TTE, 3D and 2D, and we will use the TEE, using the transgastric view, using the deep transesophageal view, and using the 3D capabilities mixed with the CT, and sometimes we have to use also the ICE catheter. Thank you very much.
Thank you very much, Erwan. This was very enlightening with the different procedures and how you managed to obtain the best images. And indeed, one of the questions that the audience sent us, in this case, Dr. Chavarriaga Quinceno, ask us, knowing that 3D echo is essential in the procedure, what do you do when you have a poor image window? What are your tips and tricks?
That's an important question, actually, because if I discuss just the use of clips, if you are not able to see perfectly the leaflets, you shouldn't go to the operating room to implant clips, because you will not be able to guide the implantation of the clips. So it means that before the selection of the device that you will use, you have to make sure that the imager can see optimally the septal leaflet and all the other leaflets. And you have to prepare the implantation with the interventionist and to see how you will manage the implantation of the devices. If you don't see the leaflets, then you are probably to move for prosthesis, because you don't need to see the leaflet to implant the prosthesis. But if you don't see the leaflet, it will be too challenging to implant clips. So images are key for these techniques.
And for the grasping, which is the view that you use to guide the grasping, which is your favorite, or where we should go, for example, because sometimes there is the difficulties to get a good transgastric when there is a very dilated atrium.
So logically, we should use the deep transesophageal view, the biplane mode, because it's easier to see what we call the intercommissural view of the tricuspid valve and the opposite view. But it's not always easy to see perfectly both arms in these views. So we usually use the transgastric view, actually. It's not optimal sometimes because we just see the motion of the clips from the RV to the annulus, and we just have to be convinced enough that we grasp enough leaflets when we do so. But of course, we will use afterwards the transesophageal view to make sure that we have enough leaflets between the graspers and the arm of the clip. And I know that for the future, and we will discuss that afterwards, the ICE catheter will probably change the way we implant clips, because today we have to admit that something like 4 to 5% of the clips that are implanted can be staged after the implantation. So we really have to optimize the images. We really have to make sure that we see optimally the leaflets and the arms of the clip to implant these clips, because it's much more challenging than the mitral valve.
Indeed, and you already advanced or announced the following talk. And for the sake of time, I think that we can go to a simulative, who we will speak about towards reduced need for general anesthesia, and perhaps there the intracardiac echo catheter, as Erwan said, plays a major role. What is your opinion in this, Asim?
Thank you, Victoria. And it's a great point to pivot to my talk, especially as everyone mentioned, many of our patients may have suboptimal imaging, and so we need other modalities. So I'm going to talk about, as an interventional cardiologist and a structural interventionist, I'm always looking for ways of making procedures less invasive and moving away from general anesthesia. That doesn't, though, mean I'm trying to move away from my echocardiography colleagues, because what I'm about to show you, I think, as far as ICE, can't be done without working together with an echocardiographer. So, many of the cases that we've done, all the ICE cases we do here at Monty are done with one of our echocardiographers, and usually Dr. Ho, who's a real expert in it. So, why think about ICE? Well, here's a study just looking at, for example, patients with LAA closure in the United States and how the risk profile of these patients is increasing. We're seeing more and more patients with multiple comorbidities who need to undergo procedures. And so general anesthesia in some of these patients may be a limitation. There are more patients with lung disease, advanced heart failure. But also, with a lot of these comorbidities, such as lung disease, there may also be more challenging windows in which to really see and do TEE. Even though, all three of you are expert TEE operators and I'm sure have very limited complications, it is worth knowing this article that, what they did was they did gastroscopies after TEEs to see how often do patients have injuries. And, it's important for us to realize that it may happen. It may happen often. In this study, there was a new injury in 86% of patients with complex lesions in 40% of patients. And some of the predictors were longer procedural time or poor suboptimal image quality. That just sounds like a tricuspid procedure by definition, right? Longer procedure time, tricuspid valve further away. So I worry about this in our tricuspid patients, particularly because they also have right-sided failure, congestion, and so this may be a reality that we need to think about. So currently, when we think about ICE, most of us have had experience really only in 2D ICE. And, here where I work in the United States, in New York, we use 2D ICE all the time for our PFO closures. But there's more and more work now to use 2D ICE as well to guide LAA closures. Here's a picture from Mohammed Al-Khuli, who I think is really one of the people pioneering using ICE for LAA closure and not doing general anesthesia. And you can see how, with some experience, you can really get very good imaging, even with 2D ICE to do LAA closure. There may be some more complex LAAs where 2D ICE is not sufficient, though. And then when you think about tricuspid, edge-to-edge repair, like everyone said, look at this case, the TE imaging on the left, good transgastric views, but look at the grasping view. The grasping view was really not great. And in a case like this, just adding even a 2D ICE catheter can be really useful because it can really show you leaflet insertion. The problem, though, with 2D ICE is you really sometimes need quite a lot of manipulation to find the right two leaflets. And that can sometimes be a true challenge when trying to do 2D ICE. Forward to my next slide. So we've used a lot of 2D ICE in these kind of indications. I think the other one that was mentioned earlier was Cardioband. And I think even you, Victoria, have some experience where there are times you can't see some of those anchors. And the addition of 2D ICE here, you can see where you can really see the hinge point a lot better with 2D ICE. However, we now live in a world where there are 4D ICE catheters. Here are 2 of the 3 4D ICE catheters. There's also one from Siemens. We've had a bit of experience with both of these catheters here at Monty, but we really done a lot of work with Biosense Webster New Vision ultrasound catheter. So this is a 4D ICE catheter that connects to the GE system. I think the technology is very interesting because you have a wide 90 by 90 degree field of view. So you do have true multiplanar imaging. The penetration depth about greater than 50 centimeters. And you both have the ability to look at the elevation coronal planes and have typical biplane imaging. The catheter is also unique, and I'll show you that in a second. It's a 10 French steerable catheter with an independent tip rotation. And you also have really good color flow Doppler, 2D and 4D color flow Doppler with both PW and continuous wave spectral Doppler. So the catheter here is unique. This catheter is different to the other ICE catheters and the other 4D ICE catheters. So most other catheters have two angles of flexion, right? You have an anterior posterior and you have a left and right. What's different with this catheter is you only have one axis of rotation, as in flexion, active flexion, so posterior, anterior, but you have another knob that allows you to rotate the crystal and sort of rotate it independently. So, we used it recently, and it's just really interesting. You're sitting in front of a valve, and now you can really rotate independently across the valve and really see the valve in a much better way. So this independent rotation, I think, is unique to this catheter. It's the only catheter where the distal tip has independent rotation of the transducer. And I think that's potentially a huge advantage when you're trying to do particularly valve studies in this patient. So I'd like to share with you some imaging. And initially, I'm going to share with you imaging that we have, particularly from, these were all preclinical work we did with the New Vision catheter. So here you just see an example of the mitral valve on top and the tricuspid valve at the bottom, just showing you the type of imaging you can get. Very good 3D imaging, very good flexi slice. And even, if you look at the mitral and tricuspid valves on 3D, really impressive imaging. And it'd be hard to sometimes distinguish this from TE. Here's an example of an LAA closure done with the 4D ICE using the Amulet device, where again, having the ability to use flexi slice really allows you to be sure where you're implanting and that you're getting no leak. Here an example, for example, of a Watchman, and you can see on the bottom left picture where the Watchman's been implanted too deep. On the top right, where it's too proximal, and then a good position on the bottom right, again showing you the quality of the imaging. We also here showing you some examples of using the 4D ICE catheter to do tricuspid clipping. And here essentially, our experience has been very positive with the 4D ICE. You can literally, get a inflow-outflow view similar to a deep esophageal view, and then just leave the catheter there, and then you can biplane off that, and then really be able to tell and see your clip arms wide open, and be able to see both an anteroseptal and a posteroseptal grasp very well. So I think we now have started adding 4D ICE to all our tricuspid clipping cases here in Monty. And what we found is, for now we're doing both. We do TE and 4D ICE, but having the additional 4D ICE has shortened the procedural time significantly because you can really see good grasping and good leaflet insertion in minimal time using the 4D ICE. And so we've been really surprised how it's, to me, is essentially, I think, going to be a game changer. I'm not sure whether we're ready to only do ICE-guided tricuspid clipping procedures, but it'll be interesting. So, I showed you a lot of preclinical work. We've now started using the New Vision catheter since yesterday. We did our first clinical case with it here at Monty, which was a tricuspid valve-in-valve. I just wanted to show you some of the pictures from it because these were pictures taken yesterday. And here you see, on the left, or the pre-procedure 3D showing you the stenotic valve, and then post-valve-in-valve on the right with really, I think, phenomenal imaging that really for us was great to see how well you can do this. And also doing gradients was pretty easy and consistent as well. So I really do think 4D imaging with ICE is going to have lots of benefits. It will allow us in the future, to hopefully do some of these procedures with conscious sedation. All of us have patients who can't be intubated because they have varices or they have other issues, and who also have mitral or tricuspid valve disease. And so those patients need an option. I think as an adjunct to TEE for tricuspid procedures is going to be very important. But I definitely think within the next few years, we'll see more and more reports of patients being treated on the tricuspid valve in particular, and probably also on the mitral, using only 4D ICE catheters without intubating the patient and doing these under sedation. So I just wanted to give you a flavor of what I think is going to be the future and how we're going to apply 4D ICE catheters in our structural procedures. Thank you.
Great, Asim. That was a wonderful view to the future, actually. And you made us smile at the moment that you say moving away from anesthesia doesn't mean move away from the echocardiographer. But since you are showing eyes, and mainly the eyes probe is manipulated by the interventionalist while the echocardiographer is adjusting the console or adjusting the color scale or everything. What is your view? Which procedures you think that TEE will continue as the main imaging technique? Which others do you think that perhaps the transition to ICE, to D or 4D ICE will be faster, for example, at the moment that you also gain your knowledge and your skills in manipulating the probe, because it's not always easy, even for imagers?
Yeah, no, I think that's a great question. So let me answer the first part about the probe manipulation and the echocardiographer. So we've actually, we want to teach our echocardiographers. So we've asked them to scrub in for the procedure and to manipulate the probe and to get the feeling of what the probe can do. And so they do that. But it's interesting what I found, right? In the cases we've done now over the last 2 weeks, there's actually very little manipulation of the probe. Once you get a good image, to the image of the probe, because of all the function you have with biplane and with flexi-slice, I've had to manipulate the probe very little, actually. I've actually been able to just leave it there, and then Edwin Ho does all the work on the machine. And there's actually a lot of work to be done on the machine, because you can really, optimize your imaging planes. You can decide, your two biplanes or what angle they're going to be. And by doing that, you can actually do a lot. As far as your second question, what procedures will be, I think, moved towards ICE? So, we've decided as a group, we're going to initially do both together as we learn and then feel more comfortable. But I think certainly the procedures that I think will move to ICE in the very near future will be LAA closures. I think ASD closures as well can be very well done with ICE. I think transseptal procedures such as mitral valve and valve will also move to all ICE and awake patients, because I think now we can, with a 4D ICE catheter, we can be better at the transseptal puncture and getting in the right position. And then I think tricuspid procedures will also start moving more and more to ICE. If you think of a valve procedure like the Intrepid tricuspid procedure, where you don't have to see the leaflets at all, or leaflet capture, or even the one that Erwan showed with Topaz, where you're not capturing leaflets, and all you care about is coaxiality within the valve, I can see that being done by ICE. I think we're still far away from mitral being done in a consistent way with ICE, so mitral clip and mitral TMVR procedures, because I think part of the challenge there is, both your big delivery system plus the catheter across the septum, the interaction between the two catheters. And I also don't think we're there yet where we have the workflows to consistently find all the images you need to even do a mitral clip.
That's a great overview. And you said the learning curve is important, and the experience. And the more you do, the more you see. Vincenzo Cesario asked us if you have ever experienced any cardiac complication with the ICE catheter.
I think, Vincenzo, that's a great question. I'll make you aware that, the Siemens catheter, which was the first catheter to offer some 3D, was taken off the market for a while because it was being used a lot for LAA closures. And because the tip was very stiff, they had some LAA perforations. Okay. So I think that is a concern. I think from what I've seen now with both the Philips and the GE catheter, the New Vision catheter from Biosense Webster, the tip is not as stiff. So I've personally not had complications, but we are manipulating a catheter inside the heart. And I think whenever you're doing that, you have to be careful. We do these with fluoroscopy so we can make sure that the catheter is not doing funny shapes. We also, when you feel resistance, we're very careful. I think the part where I'm most careful, Vincenzo, is when I put the catheter across into the left atrium, getting that manipulation across into the left atrium, making sure that the catheter doesn't end up in the left atrial appendage, for example, because I think if you accidentally pushed it into the appendage, you may cause a perforation. So it does require you being careful with manipulation.
And how do you advance the ICE catheter through the interatrial septum? Do you use an Agilis catheter or something else?
No, so what we've done is if we're doing an LAA closure or if we're doing a mitral clip, so for example, with a mitral clip, because we've been trying to learn, I have a couple of patients, Victoria, one who has severe rheumatoid arthritis and he can't be intubated and he's got severe degenerative mitral regurgitation. He just needs one clip in A2P2, okay? And we can't intubate him. So we've been learning how to use ICE in order to be able to do a mitral clip on him, ICE guided. And so we've been doing it in combination with our TEE. And so what we do is we'll go across the septum with a transseptal guide catheter. Okay, so across our stiff wire, dilate the septum and then pull the guide catheter back again, and then advance the ICE catheter through that hole. Similarly with LAA closure, we'll advance the 12 French sheath across the septum, then pull it back, leave the hole there, and then advance the ICE catheter through that hole. And I think with some gentle manipulation and using the flexion on the ICE catheter, you can get it across the hole pretty well, but you need a slightly bigger hole, right? So in all these procedures, we do make the hole bigger.
Well, and needs a lot of experience and practice, I'm sure. So we are almost approaching the end of the webinar, but there are some questions still left. And one that is kind of repeated is, for example, in patients with severe tricuspid regurgitation and pulmonary hypertension and congestive heart failure. And that's a question for you three all that have experience with these procedures. Is there any maximum acceptable of pulmonary arterial pressure to decide to go further for transcatheter intervention, or do you think that there is a value where transcatheter intervention is going to be not beneficial and not helping that patient?
I can start to answer if you want. First of all, we know that if there is a discrepancy between the right cat and the echo, probably the patient is not a good candidate because the prognosis is very bad. This is the first point. So we have to check the right cat and we have to compare the value that we have in echo and in using the invasive approach. And then according to the studies that are ongoing, because we are still waiting for these studies, we have no randomized studies showing that there is an additive value to treat this tricuspid regurg. So we have to wait for this randomized study. But in that randomized study, the cutoff for the systolic pulmonary arterial pressure is 70 millimeter of mercury in US for the triluminate pivotal trial. And the study that we have in France, the cutoff is 50. And actually, when we discuss with the person who allow us to have this patient in the studies, most of the time the pulmonary pressure is important, but the capillary wedge pressure is even more important because all these patients have heart failure with preserved ejection fraction. And we have to make sure that we can decrease the capillary wedge pressure before that we treat the tricuspid valve regurg.
That's
I'll
very important
maybe make a
information.
comment as well. Like Erwin said, all the clinical studies here in the US, including the valve studies, have a 70 millimeter cutoff. But there is some data from the TriValve registry where we've treated patients with higher pulmonary pressures. But the most important factor is whether it's precapillary versus postcapillary. So I think the ones where it's postcapillary are probably likely to benefit. The precapillary ones we tend to avoid when they have higher pressures.
Of course.
So that's great information, and this has been a wonderful webinar showing us the journey of the patient with tricuspid regurgitation. I thank very much you all, Erwan, Asim, and Denisa, for the excellent lectures. I thank also the audience for joining us, and I hope that you have enjoyed as much as we have done this webinar. With this, I would like to close the webinar. We have learned a lot, and I wish you a very nice holidays, very Merry Christmas, and very Happy New Year to all you.
Thank you. Goodbye. Thank you.
Bye-bye.